Hello, my name is Mark Schindel. I'm CEO of Manor. Thank you all for joining our webinar, Orthobiologics and the Equine Athlete. Today, we're very happy to welcome our expert panel, Dr. Laura Stokes-Greene from John Steele and Associates, Dr. Omar Maher from Atlantic Equine, and Dr. Tom Hutchins from North Texas Vet Hospital. Dr. Bill King, Manor's Director of R&D and Clinical, will be our moderator. The format for our discussion will consist of direct interaction with the panel on a variety of topics surrounding orthobiologics. Questions from the audience may be submitted through the Q&A function in Zoom, and that's at the bottom of your screen. These will be collectively discussed toward the end portion of the seminar. With that, let's begin our discussion on orthobiologics in the equine athlete.
Thank you, everyone, for joining the meeting. And we're going to start with sort of a broad topic and narrow down. And so our first question is going to be to Dr. Stokes-Greene. I know it's broad, but we can narrow down to interesting cases or things down the line. When equine veterinarians have a broad array of tools in their toolkit, how do you determine when choosing biologics versus steroids or hyaluronic acid or many of the other options available to you?
Right. So it's exciting that we have so many options now, right? I think there are three main things that I look at. The first is, what's your goal of treatment? So is this a horse in a case that is a maintenance situation where you know it's got a little bit of arthritis in the coffin joints and a little bit of arthritis in the hocks, but it's doing pretty well and you're just doing a routine check? Or is this something where you need to put the fire out and you're really having a lameness issue and you have a known arthritis case? For the maintenance cases, I tend to try and steer clients a little bit more towards the orthobiologics because I think that, you know, you've got these great growth factors. It's from the horse's own blood. You have less of a chance of having some of the other downstream effects of steroid issues, but sometimes they're just not strong enough. So that's really the goal of the treatment for that specific case. If it's something that, you know, you need to put the fire out right now, I'm definitely going towards steroids because they're so much stronger. The other thing I'm looking at is the age of the horse. For us in the hunter, jumper, and dressage industries, our age range that I'm looking at that's probably pretty typical is somewhere between 10 to 12 years old. So if this is a young horse that's just being introduced to me, then I will tend to go more for the biologics if it's younger. And then if it's a 14, 15, 16-year-old, you know, sometimes the arthritis is just too much to be handled by something like a PRP or a Prostride. And then I go for the steroid. And then the third thing is, how close to the show are we? Because if you have something that's going to go FEI, you're not going to be able to use steroids, you know, even if it's something that's a little bit minor or a small issue, your steroid use has to be pretty small coming up to the shows.
For the broader panel, when you inject with steroids, how long do you wait before trying a different modality like a biologic? How long do you wait, and what's the rationale behind that washout period?
I usually will wait at least a month. If not, if the horse comes sound, then great. I won't re-inject it. But if it's something where I know there's a known issue, then I'll wait at least a month for it.
Dr. Maher, Dr. Hutchins, similar time frame?
About similar time frame, and actually, like if we have tried steroids and that didn't work, at some point we just question what exactly is going on. So often we're going to end up going to some advanced imaging and trying to dig deeper into what the process is. Like, you know, in some cases we might go and do biologics right after the steroids, like a month after or whatever, because it didn't work. But that's a little bit of a, you know, difficult bet. And you know, if we don't know what exactly is going on and the steroids didn't kick it, that's not happened. And I have plenty of cases in which we've used steroids, it didn't work, waited later, tried some Prostride or PRP, and the horse responded. But often we'll ask more questions at that time before I take that approach typically.
Yeah, I would agree with that. I think the same thing. We don't jump off on the biologics right away. You know, if the response to steroid therapy is not good within that 30-60 day window, then I think you have to dig deeper and get some answers as to what's going on. And then maybe the biologics are your answer to therapy at that point, but you need to know the underlying cause of the lameness.
Great. Dr. Hutchins, what disciplines do you see, and how does that instruct your choice of biologics? Like, what are some common injuries, and what were the biologics you used with those?
My practice is made up of a wide variety. We see both Western performance and English riding discipline horses. My part of the practice is made up primarily of the English riding, so a lot of hunter jumpers, eventers, and dressage. The injuries that we run into, it varies with each discipline, obviously. I mean, the hunter jumpers, we tend to see a lot more front end lameness, along with some pelvic issues, sacroiliac injuries, things of that nature. Whereas dressage horses, we tend to see more hind end, stifles, and hock, just because the discipline requires more load on that part of the body. So trying to decide, as we mentioned earlier, about what are we going to use and when is dictated a lot by what was already mentioned. How close to the show are we? What's the severity of the injury, and what are we trying to maintain? In the younger horse, I agree with what we've already said. I try to use the biologics because I want to try to keep that horse stable for as long as we possibly can. So I tend to use a lot of Prostride in these younger horses. I do PRP as well in both soft tissue and intra-articular use. But if we have something, as mentioned earlier, if you've got to put a fire out, you probably need something with a little more punch to it immediately in the short term. But after that, as a maintenance tool, that's what I reach for. And if the discipline allows and we can go that way, that's what we try to do.
As a follow-up, what instructs your choice of PRP or Prostride when you're choosing one or the other? What are some of the things you're thinking about?
Well, if I've got an injury that's, or I guess a situation that's a little bit more chronic, I tend to go with Prostride because I'm sort of combining the modality of having concentrated PRP to put those growth factors, some of those healing mechanisms in there, and then the IRAP component to try to control some of that synovitis, control that flare that comes up in a chronic situation. If I have an injury, soft tissue injury, for example, say a suspensory, we see a lot of those, and I think most of us do, but I tend to use a lot of PRP in those. And either do direct infiltration of the lesion or sort of bathe the area, and then combine that with some other adjunctive therapies like shockwave therapy or laser, things of that nature.
Great. Dr. Maher, what's your experience been with biologics in synovitis or cartilage fibrillation, meniscular degeneration, sort of different disease processes in the joint, rather than people in the past talked about arthritis as a singular thing, but there's a lot of different things that can happen depending on the joint. So I'd be curious to hear your different experiences with those different.
For a typical acute synovitis that just happened and it's just a acute flare, typically I'm going to range more towards something like steroids, like a very short-acting steroids, and that usually takes care of it. And if there's nothing underlying, that's where my first choice would be, and typically works. If it's a horse that's a bit too young and I don't want to use steroids on, or if he has any metabolic issues and steroids are too risky, I might go to something like IRAP that just has a quick, shut down the inflammation and fast way. If I'm dealing with something more like a cartilage defect or chondromalacia or whatnot, my typical protocol for that is 2 to 3 doses of Prostride a month apart. So I do 3 doses a month apart. Those horses usually I'm giving them some time to recover as well. And I'm typically going to do 3 doses of Prostride a month apart. And typically, again, follow up with a polyacrylamide gel in the joint. That's just what I do in those cases, especially if there's any bone involvement and whatnot. Like I want to try to help heal, or try to heal as much as possible the joint, quiet down the inflammation, try to promote the healing process to some extent, and then I want that lubrication from the polyacrylamide gel after that. Going to the meniscal degenerations or meniscal tears, my preference for those is I might use PRP or Prostride initially, but usually I'm growing some stem cells. And if I have a known tear in the meniscus, and typically I'll go to surgery to clean them up, but even after that, I'd probably use stem cells, and I try to do another thing of at least 2 injections of stem cells a month apart to get them functioning. So that's how I tend to approach it. Again, like everybody else said earlier, the age makes a big determinant when dealing with a synovitis. If it's a really, really young horse, or if it's an old horse with metabolic issues, for sure I'm going to move to something like IRAP or Prostride. If it's an average age horse and it's just a quick synovitis that happened for the first time without any other structural defect, a little dose of short-acting steroids usually does the trick, and you don't have to look at it again.
I think Dr. Stokes-Greene had a question she wanted to ask there.
Yeah, two questions for you, Omar and Tom. Also, do you have a preference between Arthromed or Notrex personally? And also, when you're doing these injections, are you ever putting steroid in with them?
Okay. So I think it depends. I initially mostly was leaning and used, just because I was part of their initial study, a lot of Arthromed. I've been really happy with that. I've used Notrex in some cases, in a lot of cases actually, and have had really good results with that. To be just pragmatic and completely honest, I've had a couple of horses flare up with the Notrex, and it just cooled me off on that, to be honest. Mm-hmm. And that was, quite a difference, because I use a lot more Arthromed than Notrex, and I had more flares with the Notrex. Until recently, I had one with Arthromed, so now I'm back in the middle between the two. Yeah. From a little talk last year with a few practitioners that use quite a bit of Notrex, they seem to have the need to repeat it more, and I see my need to repeat the Arthromed less in comparison. And that might be a difference. I think, the jury's still out on that, but I don't hesitate to use one or the other. Just historically, I've used more Arthromed.
I've had a similar experience with, as mentioned, between the Arthromed and the Notrex, that I've had more reaction or flare, whatever you want to call it, with the Notrex, and felt like, I made some horses pretty sore with it, and made me a little bit uneasy in the early stages. And I kind of anticipate it, but I've backed off my use of Notrex, and I use more Arthromed when I go to it, and I've been pretty happy with it so far. And I feel like the flares or reactions associated with it are much, much less, at least in my hands.
Mm-hmm.
For joint injections for the panel, are you with specifically with the Prostride or PRP from Manor, are you guys using shockwave or laser or anything else? What's the rehab protocol for sort of an average joint injection case?
So for the average joint injection case, I would call it more maintenance for me. Mm-hmm. It's the horse that I'm seeing probably every 2 months, every 3 months, regularly. I consider that a pretty regular checkup. And it's something that you have a known small amount of arthritis, but the horse isn't actually lame. It's something that's only elicited on a flexion, or maybe it has a little bit of swelling of the joint, but it doesn't actively have any clinical lameness. That maintenance case for me, I tend to do more of the Prostride, and the follow-up for me, I don't use anything with it, because I'm making the case that the Prostride alone is going to help enough that I won't need anything else. For the more chronic issues where you actually have lameness and that you've been dealing with it for longer, I definitely am including in shockwave personally. I don't tend to laser the joints themselves, only more the soft tissue, but I have loved shockwave in addition to any of these modalities.
Yeah, I would agree with that. I've had the same kind of thought process and logic go along with that. We see a lot of off the track thoroughbreds that have been, retooled, so to speak, into the English riding disciplines. And a lot of those horses, for me, I see have a fair amount of front fetlock issues coming off the tracks. They've got sort of that bilinodular synovitis associated with it. And I can currently treat a lot of those with shockwave therapy and then come behind that immediately with Prostride and then continue to follow those things out. And I think I'm doing a lot of good with that. And these horses are staying sound for an extended period of time versus what I would get with just a short-term steroid HA combination. But some of those are bad enough that I've gone in there after the fact and thrown some Arthromed at them and been very happy with the outcome and protract the period between treatments. It's worked out very well.
Good. So from in talking with our customers sort of in the day-to-day, we've had a lot more discussions on the use of our products in soft tissue, especially with Prostride, but there's lots of options available. Dr. Stokes-Greene, for the typical sort of soft tissue injury that you're treating, or what are some of the common approaches that you've used with biologics or steroid or other?
I think that Tom pointed to the difference between the lesion that has a tear in it that is an actual hole that you can see on the ultrasound, which to me is very clearly an indication that you need to put some biologic in there. Usually I'm using either PRP or Prostride. I've started using Prostride more because of the ease of the small dose and the concentration, but I can't say yet that I have a strong preference between using Prostride or any of the other PRPs for soft tissue. But the thing that I have started doing more and more of, which I really like, is for the strains that don't have an actual hole in them, I've started to pepper the whole area, and I'll use the very thin blocking needles and just, every probably half centimeter, put in a very, very small amount. And that's also another reason why I liked to use the Prostride, because it was a very small amount of the product to begin with. And then I'll do it on the inside and the outside, and I will shock wave that afterwards. The idea being with that you're activating the platelets in the Prostride afterwards and helping them to release more of their, growth factors and things like that.
Very good. Any to the other panel? Any experience with biologics and soft tissue? What's your experience been? What's your treatment paradigm looking like these days?
Personally, I use quite a bit of PRP, but also some stem cells in my soft tissues. And the PRP, I try to stay away from like tendons in general. I would go maybe to branches or to suspensory ligaments, either around the lesion or in the lesion, depending if we have a hole or not. The stem cells, I tend, like for superficial flexor tendon in particular, I tend to go more with stem cells and not so much PRP. And, my typical thing is, if you have a hole, to put some intralesionally, and I do a few injections of intraarterial, every month for 3 months after that. That's my typical protocol when I have a significant, superficial flexor tendon lesion. I tend to stay away from the PRP just from the scarring point of view, and the idea that it seems that we have more repeat offenders once we use PRP in at least that tendon in particular. In branches and in suspensory origins, I don't mind. I use PRP or Prostride, and the smaller the lesion, the more I'll be more towards using the Prostride, just because I don't have as much room to stick a lot of things, and I like especially the Prostride in chronic branches. Just, I know it's a high leukocyte product, and I think that it just pisses off the branch enough to restart the healing process, and I've had good luck with that.
Just as sort of like an interesting aside, we did a soft tissue study at the University of Pennsylvania that was presented at ACVS virtually this year. So I'm not sure how many people have had the ability to see that. Dr. Ortvet, I think, will be able to mention that in our talk on Tuesday. But just very briefly, we had 8 research horses that had collagenase-induced lesions on both front SDFTs, and we saw superior healing with the Prostride versus saline. We saw better collagen 3 versus collagen 1 ratio in the tissue after they were excised. and mechanical testing of those tendons is ongoing at UPenn. So I'll be excited to see where the mechanics of those land. But there's always been this sort of debate at meetings about the if you're forming the right kind of tissue or not. And I was encouraged to see better Cal3, Cal1 ratio in that study. But the mechanics, I think, will be interesting to see too. Yeah.
Can I ask a follow-up for Omar on that?
Sure.
Just when you're using the stem cells, are you using most of them that you've pulled yourself from bone marrow derived?
And I send them to be cultured, so that's why I'll send them to be cultured. I might put a PRP or something similar around at least the lesion, depending which one it is, at the time I'm doing it, or start lasering at the time, and by the time it comes back, I can do that. I think you use a lot more of the shelf ones, and I'm be interested in hearing your experience with that. I haven't used it as much. I've started using it in a couple of cases, but I don't want to grow a tooth in a tendon if I can help it.
Yeah, I mean, that's the thing, right? It's about, a lot of it about, for me, is about the convenience of being able to order and prepare, knowing ahead of time what I'm going to have there, which is why we've used those stem cells that you can order. I don't know, again, that we have a lot of data about whether it actually works as well as the bone marrow derived stem cells. And I do a lot of the arterial injections as well, either on the horses where the people don't want to lay them up very much, like it's a strain. We're not sure how significant the strain is. It's not actually a tear. And so we're hand walking or tack walking the horse for 30 days. And I'll do more of the intra-arterial stem cells for those cases, and then recheck them at 30 days and see what's the soundness, what is the palpation, what's the ultrasound look like, and decide whether it needs more time off or if it needs more rest. And then I know we've had the conversation before also, Omar, about mixing the stem cells with the PRP, and I would love to hear a little bit more about your feeling on how the white cell count with the PRP when you're mixing the stem cells.
I mostly do that for joints, to be honest. When I mix stem cells and PRP for tendons and ligaments, I've tended to mostly use the stem cells alone, to be honest.
Good. With your experience in biologics, Tom, what's kind of the period between injections do you see typically with different modalities between when you have to do one to the next? What's that been like for you?
Well, I think if we're using steroids and HA combinations, you know, our average window, depending on the level of work and intensity of competition, how many shows are these people trying to get to in a given period? If it's a fairly routine deal, I think if I'm looking at somewhere between 5 to 6 months, sometimes with my typical steroid HA combination, if those horses start becoming refractory to that and my window starts getting narrower, I start looking deeper into what's going on. Is the osteoarthritis advancing? Radiographically, sometimes it doesn't appear that way, but if we go and do an MRI, we see that we've got significant cartilage loss, and we may not have that typical sort of defect in dent, I guess, in the end of the bone. Those I start to do a lot more biologics, and I start doing PRP, I start doing Prostride, and I tend to protract that window now back out where I'm comfortable again, so that I'm not having to stick a needle back in that joint over and over and over to get it and keep it sound, you know? So for me, the biologics become a way to alter that treatment regimen and try to keep these people on the road, keep those horses sound, and keep them competing effectively without having to retreat. You know, every time we stick a needle in a joint, we irritate it, you know? So that's what intrigued me to go into Prostride and use it much more significantly than, you know, the other IRAP products on the market, is because it seemed to be that I had to go back with those IRAPs and I had to keep retreating, sort of loading that joint to keep the flare down. And with the Prostride, I was able to go in there one time and it was sort of a one and done. And those horses that I was seeing every 4 months, now I don't see but maybe every 6 or 8 months. And that's a real bonus, both for the athlete and for the owner, because the expense goes down and the athleticism of the horse stays up. And so that's what sort of helps me steer that way, is trying to determine, just like what we've all basically mentioned, is the flare need to be knocked down right now, or are we trying to maintain that horse and keep him going down the long haul? So that's kind of how I approach each individual, is what's going on, how close is my window, and how far out do I want to be.
To the others, what's been your sort of durability with the different modalities that you've seen?
I have horses that we've injected once a year with Prostride and have never turned back. I mean, to Tom's point, I think those cases make you feel really good about your decisions, because we ideally would love to put something putting in a biologic makes me feel better, right? It makes me feel like I'm using the more natural way. I have less risk of laminitis. It feels like a better medical decision. But the question is, are you going to get the job done with it? And I think that's really the way that we're sort of going to make that decision tree. But I do have cases that respond really well to Prostride alone.
We have a question from the audience. For the times when you've gotten a flare with Prostride in a particular horse, they want to know, should we be more worried about flare in the future? Have you had I had a patient that's flared with Prostride and re-injected with Prostride at a later point in time. How has that gone?
I've had it happen to me a couple of times, and I'm almost thinking it has to be it's the individual. It's obviously not the norm in my hands. And the few cases I've had any, quote unquote flares have been with stifle injections, in particular, medial femorotibial joints. I don't know why. I've done it once and had a flare, and I've gone back and gritted my teeth and said, I'm going to do it again, not, in the immediate short term, but for the next injection, I repeat it, and then I don't get the reaction. So I don't know if it's a little bit of the body's response to just the treatment. I'm not sure if it would have done the same thing if I'd have done steroids and HA, but my experience with that particular animal, I didn't get a flare with the steroid, but I did with Prostride. Gave it Banamine for a few days and everything went down. We did a little bit of hydrotherapy and no problems, no deleterious effect. And the horse responded quite well. I didn't see it again for 10 months. So I felt like it was a success, but for the 48 hours, I was probably a little puckered, not knowing why it was doing what it was doing. But all came out in the end. And anytime I ever have had it happen, probably, a handful of times in a year out of the thousands of joints that I do, I think it's just an individual basis, and I don't really get any deleterious long-term effects from it. It's just a transient 24, 48-hour reaction.
To Dr. Maher, has that been your experience as well?
My experience from horses having flares, I haven't had many of them do that, to be honest. The few I've had, I just put them in a list that we did not do Prostride again. So I don't know how they would react if I did it again, but I just, by precaution, dealing with the owners and the PR and whatnot is like, well, we may not try that again. We'll use something different on them. So I'm happy to hear that going back doesn't seem to make another flare the time after for Tom that has tried it. I don't know if Laura did as well. But for myself, I haven't gone back in those one that flared. Again, they're really very, very few and far between.
Yeah, I agree. Few and far between, both for me in the steroid and in Prostride. I would say it's about the same because it's super uncommon, and I've had it go both ways. I have one horse that we did the stifles on with HA and steroid, and I remember the horse, everything went perfectly, and it flared, and it was a new client, and it was a nice horse, and I was like, oh my God, you go through that feeling like you were saying, Tom, like what the heck happened, reviewing in your mind. That horse actually now we only do with Prostride because the owner is, to your PR aspect, Omar, the owner is very scared of putting steroids anywhere near the horse. So, and I'm fully supportive of putting Prostride in it. We've done Prostride in the stifles again, no problem. And then I had another horse that we did the coffin joints on with Prostride, and it did flare. And probably a year later, we did Prostride again, and no problem. So I think it was just the one-off.
Bill, since we have you here, have you in those ones that have flared, have you gotten samples from the joint and looked into it to try to realize what exactly caused the flare? Or is it like, do you think it's like a very high leukocyte count that particular day on that horse you pulled the blood? And
Yeah, I wish I had a definite answer for you on this, but we get reports from the field rarely. And I will say that like on some of the reports that we've gotten, it hasn't been, I don't think, as much with the horse, but rather sometimes I'll talk to somebody and they'll have put in a couple mils of HA and Prostride together into a coffin, and I think, oh, you might have maybe just, there's too much of something in the joint where it might have just been a distension thing, but I've not seen that. When I was investigating Prostride in human medicine, I did a lot of characterization of the product in the lab, and I think we may have talked this in the past, Dr. Maher. And really, I was always looking at the ratio of IL-1RA to IL-1, the ratio of good guys to bad guys. And the only time with APS, the scientific name we have for Prostride, was on a human person who had given blood for our laboratory study, and she had rheumatoid arthritis so bad that she had had a knee replacement done like 3 weeks before giving blood for the laboratory work that I was doing. And so we've always had systemic inflammation as a contraindication for Prostride. Our device separates and concentrates, and if what's being put in has a inflammatory background, then it's probably not a good starting material to work with. It's my understanding that's much less common in horses than it is in humans, but I've heard like Lyme disease can cause systemic inflammation in a horse or something like that.
on the same note, and more for the panel, do you have a guideline of, like, horse gets a fever for whatever reason, shipping, whatever it is, when you're coming to treat him, how long, especially if you're using biologics and Prostride or PRP, how long do you wait until after that episode happened before using, their blood to make Prostride or any other biologics you would make from them?
For me, it's 7 days.
Yeah, I would agree. I'm 7 to 10 days, kind of depending on, when it happens and sort of the duration of the fevers or illness. I mean, if it was kind of one of those transient fevers, like a flu virus spike, a week seems pretty good. I don't really have any problem with pulling blood at that point if they've had no clinical signs that week prior. The chronic ones, then I would definitely reevaluate that before I would dive off and start using biologics on one. Of course, I probably wouldn't put steroids in it either if I know it's been sick, and I want to back off a little bit because I want that horse I don't want to deal with an immunocompromised horse to begin with, so fortunately, I don't see that very often. I get a few horses that get shipped from a competition or they're in transit and they want them evaluated during layovers, but that's kind of the rare bird for me.
That's a good discussion. Another area that we've seen increasing use in and increasing discussions around of biologics is their use in SIs and facets. Dr. Maher, do you use biologics ever in those, or what's your thought process with those horses?
Thought process is again similar. Most of those are going to be the older horses that have some metabolic disease going on, and we cannot use steroids, so we'll use that. Or not as commonly young horses. Usually they don't have as much issues with their facet joints and hopefully their SI, but it's a fairly common thing to do on any horse like 14 or 15 and up. If it's the there's any hint of metabolic issues, we'll go to that. As far as volume or whatnot, I would typically use Prostride. I would typically use at least a kit per joint for the facet joint in the neck, for example. And I know it ends up being really expensive, unfortunately, for the client, but I have a hard time with the dividing thing and expecting it to work. And the few I've done with less, I seem to have had less of a response, and do that. For the SI, if I use that, I'd probably use the PRP just to have a bit more volume expansion. I'll still use 2 kits for each SI and divide it between the cranial and caudal approach. So I tend to be kit intensive on my horses, and just feel that treating a giant joint, I can't expect what's going to work in a small joint to do the same job in a big one. And I tend to use quite a bit of it. So
what kind of durability is it similar to other joints, the facets, the kind of that you see, or what's your experience been like?
Yeah, when I treat facet joints or like spine in general, I don't really want to retouch those horses any more than every at least 6 months to a year. And usually it works well. But again, it depends on what the horse is, how bad the arthritis is, and what you're dealing with. Like there's some that, I might try Prostride and I might see what that does. And if it doesn't work, I might move to steroids because, at the end of the day, the horse needs to function. And I can avoid risks and try to promote healing and whatnot. But if it doesn't do enough, I'll have to go to the harder way of doing it. So yeah, I have pretty, like, and the ones that I use for that, again, they're not usually crippled by it or whatnot, but the response seems to be good and usually lasts me a year.
That's great. Have others had similar experience or different experiences with SI or facet with biologics?
For me, I think it also depends on whether you can actually identify arthritis in the facets on your ultrasound exam. If you can, I think those are better candidates for using the Prostride or the PRP because you're treating an actual arthritic area. I mean, you can't make that assumption on the SI because you can't really see it. But at least with the facets, that makes me feel like it's a good choice. I tend to use more steroid for SIs and the facets because I do believe that a lot of it has to do with epaxial muscle and psoas muscle spasm. And I don't feel like you get the same level of relief from the spasm with the biologics that you do with the steroid, being the anti-inflammatory that just bathes the whole area of all those muscles.
Yeah, I would agree with that. I have a difficult time with the use of biologics in the SI joints. And Bill, we've talked about this before, is you're treating such a large area that I don't even feel like that if I do a PRP kit per side, that I'm adequately getting enough volume. So in those situations, I'll expand that a little bit and use the platelet pore fraction a little bit, just for a little bit of volume, just so I can have a little bit more playing room, so to speak, to be able to treat those areas. I've done a few, I've not done cervical facets with any of the biologics. I have done the lumbar area and the lumbosacral area with PRP and been pretty happy with that. But again, sometimes I have to combine that with some muscle relaxers because, like Laura said, you've got a lot of tension back there, and you need to relax that area as much as you need to treat the joints. And I'm looking at those with ultrasound and with high power radiology to see the changes in those lumbar vertebrae to try to treat that area. But cervical stuff, I tend to stick with steroids and some HA, and I have pretty good luck with doing that. So I hadn't changed.
I have used the Prostride for the cervical facets as well, and I feel like it's a great alternative, especially for the metabolic horse. But to your point, Tom, I do go to the steroid first, usually.
We have a
count or do the math of how many end up with biologic in the spine compared to that. It's probably like a 90-10. 90% steroids and 10% that, and those typically are because they are metabolic horses. We cannot the fat dressage horses, it's like you're looking for trouble to happen.
Sure.
But I've been quite happy, unless they've been really bad, I've been quite happy with the response and the length of the response.
A question I wanted to ask to all of you is, when you're talking about biologics with your clients, how do you discuss the value proposition of a biologic versus a steroid or the other options? Like, what's that conversation like for the three of you?
I think, again, it depends. Like, it's really easy when you have a metabolic horse that foundered in the past or that is at risk of foundering. Like, it's a no-brainer. Like, you want to take a chance or you want to try that. If that doesn't work, we can always try the steroids later.
Mm-hmm.
And I think it's really easy as a value proposition in a horse that's at high risk. In the young horse that's, under 5 or 6 years old, like, I just basically tell people, like, do you really want to put steroids in a 5-year-old? And, especially like in our discipline, horses have a useful career for, at least until they are 15, if not 20, if not more. So if we have to start using a bunch of steroids on a 5-year-old, I think it depends on, the people. If it's a sales horse, it's going to go to the cheaper option for sure. And the clients are going to want that. But for somebody that have their horse and it's their horse, they're going to want to go that route really easily. So typically, like, you don't have to work that hard at making that proposition. Like, it's usually the right clients are going to take it as it is, sometimes to a fault. Like, sometimes you're like, I really want to use steroids on this horse, and the client's like, no, I don't want to use steroids on him. And like, now you're fighting the opposite fight.
Yeah, we see a lot of, for me, the argument is the point of, in that young horse, particularly the Western performance horse that we see, because, we're dealing with the futurity horse that needs to compete as a 3-year-old, or a 2-year-old coming 3 kind of situation. And all of a sudden you start seeing these things that have OCDs in their stifles, or they've got subchondral bone cysts, and you're already having to throw steroids at them to keep them sound. My argument is to look at some radiographs and say, hey, I've done this, and radiographically I see improvement. I've had several cases that had subchondral bone cysts in the medial femoral condyle and used Prostride only, and followed those horses out and not re-injected them for 8-10 months and re-radiographed them, and had improvement in the cyst without doing any sort of arthroscopy or arthroscopic guided injection. So
What
I feel
age
pretty
were
good
those?
about that. Pardon me?
What age were those?
2- and 3-year-olds.
Okay.
With the cutters and reiners, they get hammered on pretty intensely as a youngster, and their lifespan is pretty short, much like a racehorse. I mean, once they get to a 6-year-old, the aged event year, after that, they're probably transitioned to a turnback horse in the cutting world. The racehorse, not much different. The racehorse has a pretty short lifespan once he gets through his Derby year. There's, for quarter horses, they're pretty much done. For the thoroughbred that can continue to race into 6, 7, 8-year-old year competitively, there's not many, but there's some out there, and it makes it nice given the therapeutic thresholds and RCI guidelines that say, hey, we can't use steroids on these horses. We can't put them that close. So Prostride and PRP is an easy sell and a very logical one in those situations. And if the response is there, it's a win-win for everyone.
Yeah. I think also there are the certain cases that the chronic issue, and you've been dealing with it, and there's a show coming up that's pretty important. And so you've already prepped the client, the owner, the trainer, everybody in terms of, okay, let's do the steroid injection at this point. Let's follow up and hope that we don't need to do anything. And if we do, we still have this window that's, however out from the show, that of this specific show, that that you could do it again with the Prostride and help it that extra little bit. And that also tends to be a sort of a methodology that people are on board with and are willing to go for.
For sure.
It's been, for me, a sort of an interesting journey from working on it in the lab before it had treated anything to it becoming a verb. Like I hear from veterinarians that clients will have asked to have their horses prostrided. And so it's just been an interesting transition there from you know, me in the lab and some coworkers to today to hear these interesting cases of how you all have helped equine athletes and their owners. It's been it's really great to hear the real world learned experiences from you to keep learning more. All right, I think Mark's going to join us now.
Thank you all to our panelists, the expert panel, for their thoughtful responses, shared expertise today. I want to thank everyone who joined the online meeting as well, and special thanks to those who submitted questions. If you had some questions that you weren't able to ask or didn't get addressed during the broadcast, we will be follow up via email. We hope this broadcast has been insightful in learning about new technologies and ways to implement orthobiologics into your equine practice. If you would like to learn more about Manor products, including Prostride APS, Restogen PRP, or Centrate BMA, please visit our website at omveterinary.com, or feel free to contact us by email at info@almanormedical.com. Again, thank you to everyone for your participation. We hope everyone continues to stay safe and healthy, and wish you all happy holidays. Thank you.